Dr. McGuire has done for the Academy. As many of you know, he's been a past president of the Academy. He's currently president of the Foundation. He has received 3 of the major awards, the Robinson Regeneration Award, the Clinical Research Award, and this year, the Gold Medal Award. Dr. McGuire practices in Houston, Texas. He started there, did some training at Baylor, worked through Emory, and then eventually wound back in Texas. He is a part-time faculty member of both of the UT programs in San Antonio as well as Houston. And I'm sure many of you know, just like our other speakers in this particular session, he's lectured internationally, published in many, many textbooks and many journals. So I don't want to talk anymore. It looks like they're set. Let's listen to Mike's presentation.
There you go. Thank you very much. I think Dr. Reynolds really set the stage well for my presentation and probably Massimo's as well. It is a pleasure to be here. I thank the organizing committee for the invitation. You know, I'm absolutely convinced that in the future none of us are going to be doing any passive surgeries at all. Everything we do will have an active component to it. And these active components will make our outcome more robust, more predictable, less invasive for our patients. And I think it's tissue engineering that's going to provide the active components that we're going to be using. I think of tissue engineering as kind of a broad matrix. And on one end of the matrix we have live cell therapy, and on the other end we have biologically active molecules like growth factors. And I'd like to share with you today a few studies that we've done using both of these novel approaches to achieve biosurgery. I think it's appropriate to disclose that I am a paid consultant for Organogenesis at this time. I have been a paid consultant for OsteoHealth in the past, but I always maintain complete control of the content of my lectures and the reporting of all data. In addition to that, when we get to the study with root coverage with the OsteoHealth product, I used a technique that varies from the FDA-approved instructions from use, and they asked that I include that in my disclosures here. So let's begin with the live cell end of the tissue engineering matrix. And you know, as you begin to get into this, we're really changing the way we think about grafting. And you almost have to deprogram yourself from what you expect a graft to look like, a graft to respond to, in the way that we've all been taught and the way that we've worked with grafts in the past. And as you move into soft tissue engineering, there's been 2 really kind of basic lines of research. People have looked at biologically based devices and live cell based devices, and they differ a great deal. Now, biologically based devices are basically just a biocompatible surface. And the one that most of us in periodontics are going to be most familiar with is acellular dermal matrix. You know, it's cadaver skin. They've removed the cells, leaving the collagen, the extracellular matrix protein. It is, in essence, an immunologically inert allograft. It will support fibroblast migration, revascularization. But basically, it's just a tissue replacement graft. It's a dead piece of tissue. It brings nothing else to the party. Very different from live cell-based devices. Live cell-based devices bring with them not only cells, but a whole host of cytokines, important for the inflammatory parts of healing and regeneration, important for angiogenesis. They bring collagen. They bring all sorts of extracellular matrix proteins that are necessary. And most importantly, theoretically, they can deliver this on demand. Dr. Reynolds mentioned that oftentimes you need a lot of different things going on at the same time. It's a cascade. It's not a simple event. And the exciting thing about this is we may be able, through these live cell devices, to overcome some of the challenges we've had in the past. You know, we've taken very potent growth factors and we placed it in the defect and waited for magic to happen. Oftentimes magic doesn't happen. Why is that? Well, how do we know that growth factor actually got to where we wanted it to? How do we know it was viable once it got there? How do we know it stayed there long enough? Maybe it stayed there too long. What was the concentration? We've had very difficult times in managing that. But these cells, through surface receptors, talk to each other. And they can have the potential to talk to the native environment as well, the defect, and they can physiologically titrate the amount of growth factors and all the other things necessary for regeneration. And the material that we've been using, doing our research on, is bilayer cell therapy, so that's what we'll be talking about. But again, you have to kind of change the way you're thinking about grafts. When you and I are faced with a defect in the oral environment, traditionally we've had two ways that we could manage it. One is primary intention. You know, let's go in, let's mobilize flaps, let's advance those flaps, let's suture them, or let's use grafts, where we take a graft and we move it in to close the defect. In the past, we also have used secondary intention. You know, just let it granulate in, but that's fallen out of favor primarily because of pain and time and inflammation and all of those things. But you know, even with primary intention, you can sometimes end up with scarring along the scar line, or you can get a tissue mismatch from the tissue you're placing from one part of the body into another part. And whether you're using primary intention or secondary intention, all of them have a spectrum, fall along a spectrum of wound healing. All from, you know, on the worst end, big keloids to hypertrophic scars to tissue mismatches and grafts. We all know that you know, kids heal much better than I would heal. We know that fetuses heal without a scar, and certain animals like newts and salamanders, through a really unusual form of secondary intention, they can actually regrow limbs. So I think our challenge as a clinician is, how do we take what we're doing in the clinic and move it from the scar toward the regeneration area of the spectrum of wound healing? Now, when it comes to regeneration, no matter almost what model, if you think about all the different models out there, no matter what model you're looking at, whether it's neonatal or it's fetal or it's animal models, anytime you see regeneration in those models, it's always relying on secondary intention. Interesting. And bilayer cell therapy doesn't really act like a graft because its products don't hang around long enough. Grafts kind of stay there forever. When you place a graft, those cells are there. In the past, that's been the best we could do, but it may not be the way we want to manage things in the future because there can be problems with these grafts. For example, so we all know the fact that if you're using a graft that you're having to take a remote donor site, you have limitations of the amount of material you can gain, there's morbidity associated with it. But also, oftentimes there's mismatch in color, it doesn't look right, and in addition to that, if you're closing a site early with a graft, you can abrogate the latent regenerative capacity that site may actually have because you've closed it too soon. Well, bilayer cell therapy doesn't work like that. It modulates secondary intention and moves that spectrum toward regeneration, as is evidenced with this patient here with the return of natural pigmentation. Had this been grafted with a traditional skin graft, it would have never looked like that. Well, how are we going to use it in the oral environment? Well, here's one of our patients that we're going to look at later in the study, and we've got a cuspid here with just mucosa. So I've gone in, I've created a traditional little bed for my Periodontology graft. If I'm using this material just to simply make healing more rapid and eliminate scar, what I'm going to end up with is the same thing I started with. But it's just going to heal faster, the wound's going to heal faster without a scar. But that's not the way this material works. This material works by changing the trajectory of healing, actually inducing appropriate site differentiation of the cells. We have now keratinized tissue where mucosa used to be without placing a traditional graft into that area. Using that approach, we did a small pilot study a couple of years ago that was published in the Journal of Periodontology in 2008 in an attempt to create keratinized tissue around teeth that didn't have any. Now, in this study, we're not trying to do root coverage, we're just trying to go in and create a nice zone of keratinized tissue. It was a split mouth design. where we were looking at a number of safety endpoints. We're also looking at some efficacy endpoints. We're looking at the amount of attached gingiva with the keratinized tissue we're able to gain, looking at inflammation scores, color and texture match as it matched the adjacent teeth, resistance to muscle pull, probing depth, all of your normal secondary parameters you'd usually look at, but also some patient-centered outcomes, patient preference or satisfaction, and any change in recession depth. It was a 25-patient study, again, one that we were not trying to cover roots. We're just trying to simply add in keratinized tissue. Now, this is the way that the material looks. It's two layers. On the top layer, you have living keratinocytes. On the lower layer, you have living fibroblasts in the collagen matrix. And these cells, both keratinocytes and fibroblasts do not elicit an immune response. So that's not something that we have to worry about. And the interesting thing about this relationship here is that when you have keratinocytes and fibroblasts together, they're synergistic. If you look at the effect of these two cells when they're together, and you look at all of these growth factors, cytokines here, and just look at the keratinocytes, look at which ones the keratinocytes produce. They produce some, they don't produce others. If you look at the fibroblasts, they produce some, they don't produce others. But what happens when they're placed together? Because of the crosstalk, because of the synergism, when they're placed together, this bilayer cell therapy is producing all of these cytokines. And in fact, it's interesting, the look on the IGF and the interleukin 8, if you have the keratinocytes by themselves, they don't produce this at all. If you have the fibroblasts by themselves, they don't produce that at all. Yet when they're together, they're producing it. And producing an array of cytokines very similar, in fact identical, to human skin. And the neat thing about it in my mind is it is a reservoir for many of the cytokines and growth factors that you and I have already identified as important for periodontal regeneration. It's producing BMPs, it's producing PDGFs, VEGFs, and a lot of cytokines and growth factors that you know that we're looking for. Here's a natural reservoir to be able to deliver those to the site of need. Along with that, it's providing a lot of extracellular matrix components, things that are necessary for cell migration, structural integrity, inflammation modulation, collagens, fibronectin, tenacin, all of the things that we need as we go in and rebuild tissues. And it's stimulating angiogenesis. What's one of the things that gets in our way as clinicians every day? Blood supply. When we sit down to do surgery and we have surgical guidelines that we're working off of, what are those surgical guidelines developed around? Blood supply. What if we can go in and regrow our own blood vessels into the area? It has the potential to rewrite the rules of surgery, to rewrite the rules of regeneration. This material is producing VEGF, basic fibroblast growth factor, both which stimulate blood vessel formation into the area. Another problem in the oral environment is the bacterial bioburden that you and I have to work in all the time. If you cut your finger, your body produces in a quick burst a peptide called beta-defensin, but it just goes very quickly and it's gone. This material produces beta-defensin on an ongoing basis, therefore potentially lowering the bacterial bioburden where we need it in the area of regeneration and repair. So another interesting thing. But most interesting to me is the fact that it is a living device interacting with a host. If you look at this response here with these cytokines on days post-insertion, look at how some of the cytokines are actually being delivered at a higher dose, say 4 days, than they were when the device was placed into the defect. Again, that's because the device is interacting with the host. You need a little more of this? Okay, here it comes. You got enough? Okay, that's it. We'll stop. And complete proof that it's a biologically active living device is that if you wound it, it heals. And in fact, in our pilot study, we did wound it because some of the plastic surgical cases that had been done prior to that, they would go in and striate the material because it causes an upregulation of production of certain cytokines. So if you look here, here's the wound through the upper layer, at 0 hours. At 12 hours, you can see the keratinocytes beginning to migrate over the surface. By 24 hours, the keratinocytes have completely covered the surface, and by 5 days, you have a fully differentiated epidermis. Now, we're taking chromosomal material from one individual and placing it in another, so we want to make sure that that comes in, does its work, and leaves. So we looked at, in our pilot study, we did PCR analysis of the DNA of these patients, and we found no evidence of persistence on any of our patients. That also then leads in and is further support that this material doesn't act like a graft. You know, it doesn't stay around. It comes in and it stimulates de novo regeneration of the patient's tissue through modulation of secondary intention. In addition to that, we went in and did biopsies, just standard biopsies, and did H&E stains. These were then evaluated in a blind fashion from histologists, and there was no differences. They couldn't tell any difference between the traditional free gingival graft and the type of tissue we were creating with the bilayer cell therapy, just good keratinized gingiva. We chose to do this in a Z-fold with the keratinocytes on the outside and the fibroblasts next to the periosteum. And we did it primarily because in an earlier studies that I had done with earlier generation material, we found that the Z-fold was more effective for a number of reasons, and it just improved handling characteristics. Now this, of course, is what we're trying to avoid. We don't want to have a big area on the palate, or even a little area on the palate that's going to cause pain or bleeding, morbidity, and we want an unlimited amount of donor material. So we're not having to just treat those areas in most need. Now, even we, during the early pilot study, still didn't quite have our arms around what it is we're working with, and we standardized the width of the grafts in the pilot study to be 5 millimeters. You can see here my free gingival graft is 5 millimeters. Well, we also standardized the bilayer cell therapy. But as we moved forward and got a better understanding of how this is working, again, it's not working like a graft. So there's no reason to think that you need to kind of standardize that, because it really doesn't make any difference. This material comes in this bioreactor. It's fresh, never frozen. And I'm about to come in and remove, I'm actually wounding the material here. I'm just going in, making a couple striations. You could graft the entire mouth with the amount of material that's in this bioreactor. And I'm now just removing it from the little well that it's in. The nutrients that it's growing on are underneath that. And I'm now creating our little Z-fold. I'm just folding it back, and then I'll bring it back, kind of like you would a sheet on a bed, or a letter you're going to put in an envelope. And because the pilot standardized width, we're just making sure it's 5 millimeters wide. And I found the best way to get it out of there